complaint. Oh, there you go. We have a chief complaint of bilateral upper extremity swelling and pain. There's a 30-year-old male that presented to the ED after having 3 days of bilateral upper extremity swelling and pain in his forearms, wrists, lateral. Wait, I think I already presented this. I'm so sorry, friends.
What was that a case of? I don't remember that case.
Yeah, I cannot say it, but please in the chat, like quickly, just let me know, because I think this is a very small, very small one, but I tend to present this kind of cases. I think. Oh, but that was
like, yeah, that just sounds very familiar.
Right? I already presented something like this. That's very, very close to this. And I forgot to put it on my drive of overrepresented cases, like emergency cases.
It's a very good case.
Yeah. I know, but I really forgot to put it in my already presented. Let me see if I have enough.
That's all right. As Yaz is looking too, if anyone else has one that they feel like they want to present, please don't be shy.
Hi, this is Colin from on the ER.
I have another one. I will try to, like, this is a very interesting case, and I hadn't presented this one at all, but let's see. So this is a case of a 36-year-old male that came to the hospital with a referral from a neurologic clinic for a 4-week history of acute urinary retention. That's the chief complaint.
All right. For the sake of time, Yaz, why don't you go ahead and just give us the HPI as well?
You're completely right. So this patient had acute urinary retention of 4 weeks, and 2 weeks after the onset of this retention, he started noticing saddle anesthesia, bilateral lower extremity paresthesia, and bilateral leg myoclonus. He described it as this rhythmic contracting movements that were afterwards defined as myoclonus. Should I go ahead and give you more?
Sure. Yeah, whatever's left in the HPI, and then we can pause there. This is already shaping up to be a good one.
Okay, perfect. So I have it, since I have this case a little bit differently prepared. That's why like my format is not the best one. But when he arrived to the hospital, he still couldn't go, he still had acute urinary retention when we saw him. He mentioned no abdominal pain, no dysuria, no pyuria. He actually mentioned that, should I go ahead and give you past medical history too?
That's okay. Yeah, we can just stop here with the HPI. This seems like a great place to jump in.
Okay, and
thanks.
Also, then that's basically it on the ROS that I have on top of my mind.
Awesome. This is a great start. You know, I would just say maybe I'll talk briefly about sort of just a general way to think about urinary retention, and then turn it over to Sharmiz to sort of layer in some of these other symptoms that we have here. You know, urinary retention, we can sort of build up an approach to it by just thinking about what types of things are required for our ability to void or to empty urine, right? And what essentially we need 2 things. We need the bladder to be able to contract effectively, and we need sort of an open track from the bladder to the urethra and out of the body. And so the two kind of primary ways to break down urinary retention is to ask ourselves, is this an obstructive problem, usually at the level of the urethra, which could be related to something like strictures, but most commonly in individuals who have penile anatomy is going to be related to BPH, or it can be related to changes in bladder tone. And that can be related to a whole host of things. There's certain medications that can impact bladder tone, like opioids or anticholinergics. But most concerningly, urinary retention can sometimes be the initial onset of something happening within the spinal cord. Because while the spinal cord plays a huge role in motor and sensory functions, it also plays a huge role in autonomic functions. And if there's autonomic dysfunction happening as the result of a central cord process, then somebody potentially could develop urinary retention from that. But that sort of general framework, is this a bladder tone issue or is this an obstruction issue, can take us quite far. Obstruction is usually going to be related to something like BPH or sometimes something like a stricture. And then problems with bladder tone, you could sort of think about things that could be exogenous substances that could be disrupting bladder tone, or a primary neurologic disease process that could be interfering with bladder tone.
Yeah, I love that approach. And, the rest of the HBA definitely gives us signal to worry about a neurological process, given the paresthesia, the myoclonus that is described. And oftentimes we worry about our no misdiagnosis, which is like spinal cord compression of some sort that is leading to the obstruction and to the neurological findings. And that is like something urgent to realize and work up. And I think two things to remember at this junction is one, okay, doing a good neuro exam, rectal tone is another one. And then the second is like, what are the complications of an acute obstruction? It sounds like it's been going on for 2 to 4 weeks. And at least like, he's like he went to the neuro clinic, walking into, but again, acute urinary retention, you would worry about the backup to the kidneys, severe AKI, and oftentimes with acute retention, hyperkalemia is something to worry about. So this is someone to do urgent neurological exam on and get your labs early on and get an ECG. The other things to think about, like, why is a 36-year-old, we have concerns for a spinal cord compression, right? And, with that, like getting a good history, oftentimes like, trauma to the back is a good one to think about. He's young enough to know any like past medical history that might predispose him. And then, thinking about like asking about risky behaviors. So thinking about, IV drug use that would put him at high risk of infection, epidural abscesses. So, in terms of like trauma, malignancy, and infections are the big things, but again, too early to tell. So getting more information would be helpful.
Amazing. Yeah, I already found everything completely. The last part of ROS, because it's an amazing start, and his past medical history. So the patient denied headache, nausea, vomiting, pruritation, photophobia, neck stiffness, difficulty with speech, weakness, gait changes. He denied having any rashes or genital lesions. He denied night sweats, fevers, chill, and any unintentional weight loss. He mentioned that the reason that he came here is because the pain of his urinary retention was unbearable. For past medical history, he denies everything. He doesn't have diabetes or hypertension. He's completely healthy. He mentioned that he had never experienced these kinds of issues before. He doesn't take any medication. Family history, he mentions that his mom has diabetes mellitus, and that's it. No history of autoimmune diseases in the family. He said that he uses like socially alcohol. He doesn't no smoking, no drugs. He also mentioned that he had only one pet, a small breed dog with all vaccinations, and no allergies. If you want me to jump into the vitals.
Yeah, would you mind maybe taking us through the exam?
Okay, perfect. So for the vitals, he had temperature of 36.4, heart rate of 82, respiratory rate of 15, and his oxygen saturation was 96% on VMR. For his general exam, I will just give you the neurological because that's the only thing that we found was, for the sake of time, that was abnormal. So his neurologic examination admission revealed 3+ symmetric reflexes in all limbs. Sensory examination revealed loss of light touch and pinprick sensation on bilateral soles, and feet up to the level of the calves. Proprioceptive and kinesthetic sensations were conserved. Motor and sensory examination of the upper extremities was normal, and there was no sensory level detected. Plantar responses were flexor. Mental status, speech, cranial nerves were all normal. There were no skin or genital lesions or even mucosa, like in oral mucosa. All of the rest is normal.
All right, I'll just make a quick comment on the past history and then pass the mic to Jack for going through the exam. So this sounds like, this is someone who's like been generally healthy, now that it's presenting with an acute onset. So the question becomes like, is this something chronic that has been brewing that we're seeing the symptoms of it, or this is something that abruptly started? And in terms of like the review of symptoms, like helpful, in the setting of thinking about if this is more of a chronic indolent issues, having no weight loss, no fevers, nothing like in the background that gives you flavor of inflammation or infection. It's helpful to note, which just kind of then pushes us to thinking like this is an acute onset, perhaps. In terms of like the health-related behaviors, alcohol, just keep it in the back of my mind, thinking about the deficiencies that can happen. Although I think, again, spinal cord is where our focus is for now until proven otherwise. And I loved the fact that you got a great exposure history, Oz. All right, Jack, go ahead.
Yeah, I would just say, the exam can sort of serve two factors here, depending on how we want to use it. We could try our best to really try to localize the exam to a very specific area of the neurologic system, right? Say, is it cervical cord? Is it thoracic cord? Is it brain? Is it, the L3, L4 peripheral nerve? Or we can take more of a pragmatic approach to it and say, what does this exam tell us about the parts of the nervous system that we need more information about? I'm just a lowly general intern. I didn't say lowly, I'm just a general internist. So my ability to localize the exam to that level is sometimes limited. Sometimes I get lucky and I'm like, oh, I know that finding maps onto this specific particular part of the nervous system. But more often than not, I'm saying, what does this exam tell me about the part of the nervous system that we need more information? Is it the brain? Is it the cord? Or is it the peripheral nerves? And I think what this exam tells us is that we need more information about the cord and the distal parts of the cord, like the conus and the cauda equina. And I'll sort of elaborate the reasons for that. The first is that we have a bilaterality to his symptoms, accompanied by saddle anesthesia and paresthesias. And I want you all to upload that as features that suggest potential problems with the cauda equina, or this sort of after the cord has ended, but still within the spinal canal. The other thing that we see is myoclonus, and myoclonus is a characteristic feature of an upper motor neuron finding that tends to come, especially if it's bilateral, tends to be present if there is a myelopathy or a problem with the cauda equina. And then the other thing that we see here is we start to see what looks like maybe some hyperreflexia. And those three things together really clue us into the possibility of a CNS process and one that is within the spinal canal. We are missing one of the hallmark features of a characteristic myelopathy, which is that there's not a sensory level here, but the absence of a sensory level doesn't necessarily sway us meaningfully away from the possibility that this person really needs his cord looked at. To see, one, is there a compressive lesion? Two, is there an inflammatory lesion, like a transverse myelitis? Or are we dealing with a non-compressive, non-inflammatory central cord, or I should say spinal cord process, the list of which we could get into later. But I think the compressive process is the one that we most need to focus on and rule out. The reason for that is twofold. One, the tempo is consistent with a sort of slowly progressive nature of the symptoms, which we can see with a progressive process in the spine. Like Sharmin mentioned, that could be an infection, could be cancer, or it could be a musculoskeletal process because discs can herniate into the canal and lead to progressive compression. And then if it's not a compressive process, well, then we have at least a little bit of time to breathe before we make a decision. But a compressive myelopathy needs to be taken for decompression quite quickly. And so even if we can't say, oh, I know exactly what part of the spinal cord this is, we have enough information to say we need to get information about what's going on there. And the MRI with contrast is going to be hopefully something that can clue us into that.
Amazing. I really like the way that you're tackling this case. Honestly,
can I also, yes, I'm sorry. Can I also add one more thing here?
Yeah.
Which is a mistake that I have made in the past is assuming that because the lower extremities are the primary symptoms involved, that the lower part of the spinal cord is the place that we need to look at. And I have avoided getting imaging of the upper parts of the cord. Cervical myelopathy can be very protean and a very difficult to detect diagnosis that can sometimes manifest with almost purely lower extremity symptoms. And so given that this is somebody who has hyperreflexia in all limbs, but lower extremity predominant symptoms, we need to make sure that we're not missing the possibility of a cervical disease process, and either imaging it or having a neurologist reassure us that we don't need to take a look at the cervical cord. But that is one disease that I have missed more times than I care to admit when someone comes in with primarily lower extremity symptoms. So always remember that the cervical cord, because of the ways in which the motor fibers are layered anatomically, if the cervical cord gets compressed, you can have the first symptoms actually be in the lower extremities, even though the lesion is much higher up in the vertebral canal. All right, now I'm done, Yas, I promise.
Amazing. So I'm going to give you the resume labs. Mind you, to paint the picture of how we were treating this patient, he still didn't go through this like week, 5 days of him being at the hospital. He hadn't been voiding if like they tried to win him off the catheter, and he would keep having this urinary retention. So he was still on a catheter. This patient was still, he couldn't deambulate. So just so you can understand what I'm about to tell you. His CBC, white blood cells, everything was normal. I don't have the numbers right now. On chemistry, it was also unremarkable, as well as his LFTs unremarkable. We did a vitamin B12 level that came back low at 290, homocysteine level of 11.2, ESR of 30.9, CRP of 5.9. Other labs including creatinine phosphokinase, aldolase, methylmalonic acid, lime titers, copper level, all his antibody panels were unremarkable. Should I go on into the imaging?
Yeah, that sounds great.
So we got this patient on a lot of imaging. Basically, they did a pan scan. He had a CT abdomen, pelvis with IV contrast. There was no evidence of primary metastatic masses, of any tumor, cholelithiasis without evidence of cholecystitis. Unremarkable, basically, a CT chest without contrast. They found a small calcified granuloma in the right lower lobe with additional non-calcified micronodules. The report mentioned that it was likely infectious or inflammatory. No evidence of pulmonary fibrosis. He also got a brain MRI with no intracranial demyelinating lesions, no abnormal intracranial enhancement, no intracranial masses. And what you asked for, the thoracic and lumbar MRI with contrast, and they found multifocal thoracic cord sinus abnormalities associated with patchy areas of contrast enhancement. Diffuse enhancement of the cauda equina nerve roots, which appear to be more prominent in the lower lumbar and sacral regions. Again, thank you, Ashutosh. Shout out to Ashutosh because he has been like trying to put up with all this information. After that, CSF was prompt and also a viral panel. Would you like me to give it to you, or would you like to discuss this piece of information first?
Yeah, we can chat through this stuff to start here. So yeah, I will talk through the labs and then leave the rich imaging here for Sharmizi. I think one of the challenges in evaluating any disease is we sometimes will get lab findings that are potentially compatible with the syndrome, but we have to sort of pause before we attribute them to the final diagnosis, right? This comes up in the low back pain space quite often, right? Many individuals, when you get an MRI of their lumbar spine for low back pain, could have degenerative changes that are seen. They may have disc abnormalities or disc herniation, but just because those are present, it doesn't mean that they're the cause of this individual's back pain. We can use the same analogy in this case here with the low vitamin B12 level, right? Somebody who has vitamin B12 deficiency can absolutely have many of the symptoms that this young man has here, right? Vitamin B12 deficiency can cause like a myeloradiculopathy. So you can see problems within this or a spinal cord process develop. You can get paresthesias and numbness and loss of sensation because of the dorsal column or because of both the peripheral neuropathy that develops, but also because of the dorsal column damage within the spinal cord. And so seeing the vitamin B12 level here, right, we may feel really compelled to say, oh, we got it, right? This person has a myeloradiculopathy from vitamin B12 deficiency. But there's a couple features of both the imaging and of the exam that don't perfectly map onto that. So we may end up, right, saying that may be the final diagnosis here, but it certainly, I don't think we have enough information to definitively say that this is due to B12 deficiency yet. And that's because oftentimes the roots of the nerves are involved, which can give individuals dropped reflexes in B12 deficiency as opposed to hyperreflexia. And most importantly, vitamin B12 deficiency often doesn't cause enhancing lesions in the spinal cord. You may see signal abnormalities in the dorsal column because of the nutrient deficiency that develops in these patients. But the enhancement on imaging is characteristic more of an inflammatory process. And so I'll turn it over to Sharmin. I think B12 could potentially cause those findings, but it's much less common to do it than some other stuff that needs to be evaluated here first.
Yeah, super interesting. So I think, the spine MRI that we wanted, showing this like diffuse and then like patchy enhancement throughout the spinal cords, made me concerned about like an inflammatory process, whether that is like infection versus like autoimmune. Again, some paraneoplastic syndromes can do this as well. So thinking about like, the list that I'm running is kind of like the myelitis kind of list. So thinking about, the viral panels like HIV is another one to think about. Thinking about your infections and also like kind of the autoimmune 36-year-old, I think he's at a good age for that. And then I think neuroconsult would be really informative. I'm thinking like whether this like getting in a lumbar puncture would provide additional information that would be helpful, especially when we're thinking about like whether it could be potentially a demyelinating process going on as well. So those are kind of where I'm leaning towards, like for the serological workup, neurology consult, in addition to maybe a lumbar puncture to begin with. In terms of like therapies, I would hold off. He's clinically stable, especially with the Foley catheter in. So I see a lot of serology workup in this future.
Yeah, this patient, as I mentioned, he had absolutely every panel. By the way, a little correction. There was a calcified nodule in the CT chest in the lower lobe. And that's why he got an AC level, which was 16, and remarkable. Still, we kept on with the viral panel that came back negative to enterovirus, HSV6, HSV1, human herpesvirus 6, simple virus 1, simple virus 2, paracovirus, varicella zoster, Cryptococcus neoformans zangatii, also negative. He got a meningitis encephalitis assay comment, which was unremarkable too. EVV was non-detected. He also got cultures for Listeria and Neisseria meningitis, Streptococcus agalactiae, pneumonia, all negative. His hepatitis A, B, and C negative. And he got also a CSF fluid, like we got first before doing the everything else on the CSF. I was about to reveal my diagnosis. He got a fluid analysis of CSF. The white blood cells were 65, the red blood cells 0. Glucose was 45, which was normal according to the parameters here. He got a CSF total protein of 64, which is high. A CSF total set count of 65 too. CSF lymphocytes 88, which are high. CSF monocytes 12, which are low. And what prompted us to do a little further exploration on the CSF was the IgG in the CSF was 68, which is high. Do you want to listen to the next part?
We can maybe quickly go back and forth, Jack, and then have Yaz.
Sure. Yeah, that sounds good.
Kudos job to all the infectious workup that has been done. The one thing that I was like thinking about was reflecting as Yaz was revealing more data is that, you know, the brain MRI, and the fact that it didn't show any lesions at all, is that a pertinent negative? So thinking about, like, you know, with this day, like it's kind of like thinking about MS or some other type of disease that you would have signature on both sides, and whether that would be like a important pertinent negative to have until like the CSF results came back. So what are your thoughts on the CSF results?
Yeah, I'm with you. I think we can say now that we have a transverse myelitis or a sort of inflammatory CNS process here, and I think the sort of DDX collapses back onto all of the things that you mentioned here, Sharmeen. I think I wish that there could be some like I don't have the most esoteric approach to go with it, other than the base rate would favor infections over CNS autoimmune diseases, followed by systemic autoimmune diseases. And I feel like that's often the process through which the workup progresses here. But I think the lymphocytic pleocytosis combined with the imaging findings and the symptoms, we can sort of label this a transverse myelitis now, which gives us sort of a nice bucket to at least sort of establish the diagnosis. So many of these end up being idiopathic, but hopefully we can end up with a clear diagnosis here. And with that, I'm going to pop off for the hard stop at 2, but I'm going to be in a high suspense to know what the final diagnosis is. And yes, thank you so much for the case here. All right, see y'all.
All right, guys.
Hey, so this will be the last article. I try to resume this case that took us at least one week and a half, the best I can. So after seeing that IgG and CSF, multiple visits by neurology, by ID, even by rheumatology, because of that calcified nodule they saw in the chest, they decided to do a CSF viral detection, which was negative for all the viruses except for HSV2. The IgG titers were high. So neurology came back again. And after seeing these negative images, this enhancement, this viral titers, they kept doing more studies on his progression. This patient was put on acyclovir and he started getting better. He started actually deambulating, which basically gave us the diagnosis of Elsberg syndrome.
Wow.
So
I'm mind blown. Yes, I've only I need you all to teach me, because I've heard of it. I've never seen one, or this is the first case that we've we've been presented to. As you can see, I can't talk. Can you teach me a little bit more?
Of course. So basically, by the way, this patient, after he got, I think, his second dose of acyclovir of 800 milligrams. He started getting much better. Actually, he got weaned off the catheter at the second, I think the night that he started the treatment. Around those, I don't really know exactly, but it was almost immediately. Diagnosis of Elsberg syndrome is very rare, and it's actually much confused, quote unquote, with cauda because it also includes symptoms of sensory impairment, state anesthesia, lower extremity weakness, and bowel or urinary incontinence. And there are like very point criteria for this, like Saboldi criteria, which actually are quite new from 2017, that you have to have a patient that has these clinical symptoms and signs of cauda equina, including urinary hesitancy or retention, or bowel incontinence or severe constipation, a time course indicating acute subacute onset, and a progression over less than 3 months, and finding CSF pleocytosis. Those are the main criteria over a very interesting list of criteria. We came back with the patient when we saw that those viral panels, and he mentioned that 1 month ago, like 1 month and a half ago, right before he had these issues, he had sores. He described them as sores and like all around his mouth, but he never took attention of that because he had been having those like quite regularly. So he never thought, like, he had a flu-like illness, but he didn't even mention that, because how many times do we have flu-like illnesses and we don't really care about those? But in this case, this person started having this immune reaction against the titers of HSV2. And well, after this was basically a diagnosis by discarding everything, rheumatology, neurology, and ID were all on board. This patient was in Miami. So yeah, we did think about arboviruses, as Heman here in the chat masterfully mentioned West Nile, and we also did those titers and everything was negative. So yeah, neurology determined with ID that it was Elsberg syndrome.
Wow, thank you so much. Yeah, yeah, I have a lot of reflections to do. I think like a couple of reflections that comes to mind. So sounds like he's had this oral HSV kind of recurrent infections that he didn't really think too much of. And then somehow he has this now kind of an autoimmune reaction of his nervous system to it. Did I get that correctly, Yas?
Yeah, it's a immune reaction to the CSF titer, to the HSV2. It can be also caused by HSV1, HSV2. Even West Nile virus have been reported on across literature, and they all have found, all the case reports have shown only very faint enhancement, specifically on the lumbar roots, L4, L5 roots, and always in this saddle distribution and lower extremity motor issues. So, and I know that I see Valeria is here. I'm so sorry for saying like all these neuro terms wrong.
You're doing great. Yes, from where I'm sitting. No, that's very fascinating, because thinking about like, the HSV titers were negative to begin with. So, thinking about like, HSV, we think about like kind of meningitis type phenomena, like temporal lobe enhancements, all of that. But this is not that. It's kind of a reaction to having seen HSV, which is fascinating. I have so much to learn. So thank you so much, Yaz. I really appreciate it. What a fantastic case. And yeah, we're ready for teaching points.
Sure. Yes, thank you so much for such a wonderful case. So I'll just quickly go over some of the teaching points. So when we started with the patient had acute urinary retention, and Jack taught us a wonderful skill approach to urinary retention. We need to think about what we need to basically urinate. And first, we need a bladder that's contracting properly, and also we need to make sure that the urinary tract is clear. There are no strictures or any sort of obstruction like BPH. And once that's out of the way, we also need to consider various medications which can also impact urination. For example, opioids and anticholinergic drugs, they can also lead to acute urinary retention. So a thorough medication review can also help uncover some of those causes. And like we had in our patient, we also need to rule out certain life-threatening causes of cord compression, which we need to act really quickly. For example, if there's a tumor which is impinging on the cord, or if there is an epidural abscess, we need to address that really quickly. So we also need to think about the spinal cord issue. And Dr. Sharmin was mentioning that a good neuro exam and obtaining relevant history is of paramount importance, especially in the context of our patient, which we had. And it's important to ask if the patient had exposure to IV drug use or inquire about any trauma, especially since we were considering the diagnosis of cord compression. And also, as with everything in neurology, tempo is key. It's very important to figure out if the process was acute or chronic, and also note how the disease has evolved over the course of time. So that can actually help us narrow the differential a little more. And Dr. Jack was mentioning that the neuro exam can also help serve two factors. It can either help us to precisely localize to a particular level, or we can also take a more pragmatic approach. And we can see, based on our neurological exam, what we want to obtain further information about. So, for example, in our patient, we had bilateral we had saddle anesthesia, we had myoclonus. And so considering the fact that he had urinary retention as well, we were able to, through our exam, get a sense that we were probably dealing with a cord pathology. And so using that as key information, we then want to look at what's going on with the spinal cord. And so MRI with contrast would give a lot of information about what's going on with the cord. And he also mentioned that just because the limbs are involved, we shouldn't actually prematurely attribute the cause to a lower cord pathology, because sometimes even a cervical myelopathy can also present with pure motor symptoms in the lower limbs. So it's important to make sure that we're not missing something higher up at the cord level. And also as we proceeded towards this case, we also got a B12 level, which was low. And Dr. Jack mentioned that it's very important to first pause and reflect. Although we have certain lab values which are not normal, we shouldn't prematurely attribute that to the patient's clinical presentation. We need to see whether that is a signal or noise, and that's something which we need to do, because in this case, B12 level, although it is low, it actually doesn't explain some of the findings. For example, it doesn't explain what's causing the enhancement in the MRI, which was actually seen. So that's something which we always need to keep in mind. And enhancement of the MRI in the spine especially makes us think about some sort of an inflammatory process which is causing the contrast to leak. And so when we think about that, we think about myelitis. So that's the inflammation of the cord. So we can think about infectious and autoimmune conditions. And when we got the MRI with the inflammatory signal, it's important to know what's causing that. So it's important to get a lumbar puncture after that and work up for autoimmune as well as infectious etiology. And lymphocytic pleocytosis and the enhancement in MRI makes us think along the lines of transverse myelitis. And in the case of this patient, combining all of these, the clinical presentation and the findings on imaging and lumbar puncture, and also considering the fact that he had recurrent flu-like illnesses and also the herpes infection. So the final diagnosis was Elsberg syndrome, which is actually a post-infectious phenomena. And Yaz was mentioning there are certain criteria which we need to consider before we make the diagnosis, and some of which include clinical signs and symptoms of cardiac equina-like presentation, which was seen in the patient, which she has presented. And also the time course, which needs to fit. It needs to be a subacute and acute time course, and also the radiographic evidence of cardiac equina involvement, along with the spinal fluid analysis of lymphocytic pleocytosis.
Whoa, that was brilliant. Thank you so much for capturing so much in short amount of time. I'm always amazed about how you all do it. Yeah, can I ask you one more question in terms of treatment? So if the patient doesn't respond to acyclovir, if it's thought to be more autoimmune, is it like steroids the second line?
Yeah, actually, in the case reports, it was mentioned that mainly as one of the quote, unquote, criteria for them was that the patient had to improve in acid liver, but there has been a practical consensus that you can also use corticosteroids, but they are like really the changes are not. It's very controversial. That's the word that they used.
Got it. So acyclovir, and these patients tend to improve on acyclovir.
Yes.
If not, then maybe steroids.
Yeah, they normally get better on that, and some cases added some steroids to the treatment. Some others didn't. Again, the consensus was like you can add it or not. There are still a lot of like areas of research in this specific topic because it's neuroimmunology, and as something that I really Elena, thank you for like mentioning it in the chat, like the history, like risky behaviors, of course. This was a patient I saw as an observer in Miami. So I remember he was telling us that there was no risky behaviors, no past recent partners with like herpes, HSV2, because we definitely, that's the herpes, the mouth sores that he's mentioned, it's more for HSV1 and he had HSV2, which I remember it also created some kind of discussion when we were thinking about what would be the plan and assessment for this patient. But again, once the patient tells you that they do not have any risky behavior, one, you can give them the confidence to open up to you afterwards, or two, just if they do not mention it, we don't press on that.
Yeah. No, beautiful reflection. Yes, thank you so much for bringing that up as well. That's another point that I was thinking about, in terms of like getting histories, and I think people also what they consider risky behavior. It's very varied across
the very broad.
Yeah. So, when I think the beauty when patients are inpatient, you can always go back to them, and as you establish more rapport, you can also like circle back with them. So it's okay if you don't get everything in the first go around as you're getting to know, but like going back, and as you get more data and refining the differential, going back and like maybe asking specific questions might be helpful, as you all did. Really, really incredible case. And I can't wait to pull up some case reports and learn some more. Thank you so much for sharing. Thank you for joining us. Really, really appreciate you all. Thank you. Bye.